Well, hello, everybody, and almost happy May Day. One day later. Great to get to be with you for SADS Live 164. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. Bring you greetings, though, from our CEO, Alice Laura of the SADS Foundation. This is your nonprofit advocacy organization devoted to your SADS conditions. As you know, SADS is for the Sudden Arrhythmia Death Syndrome Foundation, and a family, wonderful family that found me through SADS Foundation this week said, I don't like that name. And when I read that name, it made me very sad. And so we've talked about the name for a long time. It is how we are known and branded. You know our strategy is www.stopsads.org, and that's our goal, is to stop these tragedies so that our families can live and thrive despite your genetic heart condition. So wherever this finds you, whether you're wrapping up your day on the Friday afternoon on the East Coast or is Friday evening in Spain, and I mentioned Spain specifically, just past or having dinner time, or down under, we're glad that you've chosen to join us. Can't wait to see who's going to join us online to tell us you're there, whether it's through whatever social media platform you're joining. Today, it's really exciting to spend the time exclusively on Brugada. So except for right now, I won't be mentioning long QT syndrome, sorry, CPVT, sorry, or ARVC. This is Brugada Day. In fact, the month of May is the SADS Foundation focus on spotlight on Brugada syndrome. So we're going to focus on that, and I'll be looking on the sidebar for questions. But normally, as you know, I only take them in order. I never, ever skip. But today I will skip them and passing over a non-Brugada question. We'll also have activities next week. Thursday, May 8th is a webinar on Brugada syndrome. Join us for that, and you're going to enjoy that. But to kick off the first Friday of May and to discuss all things Brugada, I thought I'd bring on somebody whose last name is Brugada, a dear, dear friend of mine, Dr. Georgia Sarquella Brugada, who's going to come on from her evening in Spain. So Aaron, go ahead and bring up Georgia. Georgia, so great to have you again. Welcome back to SADS Live.
Thank you. And so happy to be here and join all of you, and especially to have a nice chat as always with you, Mike, and also to be able to receive all the questions from our patients and our already friends.
Yes, indeed. And George and I were together just last week in San Diego at Heart Rhythm Society. So it was great to catch up in person, but always a treat. She's one of my favorites. We're not supposed to have favorites, but I do. And so Georgia, before we talk about things related to your last name, give us a little thumbnail sketch of your journey from here to there so far, Georgia.
Well, I think it's nice to know that probably I'm following certain path that probably, Mike, you recall very well. I'm a pediatrician myself. I did pediatrics in University of Barcelona, and then I did pediatric cardiology, and then I moved to Canada to do my fellowship in interventional cardiology in congenital heart disease, and then to Paris. And finally, I went back home to Barcelona and I did my fellowship in electrophysiology, arrhythmias, and also inherited cardiac diseases. So it's to turn the world to come back home. Nowadays, I'm leading the arrhythmia and inherited cardiac diseases and sudden death unit in Hospital Sant Joan de Déu, which is the largest pediatric hospital in the country. And it's one of the first 3-4 in Europe. It's a only child devoted center, which it makes it a little bit special. And I think this is the good part of it, that we are devoted to children and their families, and also to be able to bring all that knowledge in so rare diseases as Brugada syndrome.
Yeah, and I love your place. As you know, I got to be with you in Barcelona, and for my first time there, and loved being in Barcelona. Loved your hospital. Our focus spotlight is on your last name, Brugada, and maybe for our listeners, it'd be interesting to share how Brugada was discovered and who discovered it, at least from the Brugada brothers' perspective, and how are you related to them, since you're not the discoverer, but you know them very well.
Yes, well, I have to say that Josep and Pedro Brugada described what it's now called Brugada syndrome in 1992, and they are my mom's brothers. I share with some of our patients here that my mom had sudden death, and unknown cause. So this is also part of it. And I don't usually talk about it in public, but I feel like we are in a private conversation now. The fact is that they described the syndrome in 1992, and a lot has been known so far. But I think that one of the parts that were missing in this family role, which was also followed by Ramon, who's a geneticist, is that there was lacking the pediatric part. And I think that as we will probably talk after, how Brugada presents in pediatric can be very different from adults. And I think that that's the part that I focus the most. And I think that I could bring up that different information in the family knowledge, I would say.
Yes, and as you know, I know your maternal uncles very well, and they're just incredible men, and also the baby brother, right? Ramon is the baby of that family.
Yes, yes.
And so I've known him. So Ramon, right? For people who are trying to keep track of the Brugadas, Ramon is your
uncle as well.
Yeah. So
Yeah.
Uncle Ramon, and then there's Georgia from her mother, and as you know, we lost your mom, as you said, tragically, but there's no reason to think that she died from Brugada syndrome. She just died from tragic, unexplained sudden.
Exactly.
Yeah.
I mean, I want to think that destiny is not so cruel that to give her a Brugada syndrome, but at least we were screened, the siblings, and we don't have it. So I have to say that I don't have Brugada syndrome myself. But sometimes things happen like that, and we know that, Mike, that we are devoted to sudden cardiac death, that sometimes we don't have the answer. Right. And this is something it's very frustrating from, of course, family point of view, but also from physician point of view. It's very frustrating, but it's part of those things we have to deal with. And I understand it very, very well.
Yeah, indeed. Wow, to think 1992 when Joseph and Pedro described that. I mean, I'm doing my math in my head. That's 33 years ago. And at that time, it was just a clinical description. And my, oh my, how we've learned a lot, gained ground, lost ground in some ways. And I'm curious your thoughts. We'll do the glass half full. What key things have we gained in knowledge, would you say, that is so different than when they first described it? What are some of the biggest advances from your standpoint?
Well, I think that it always happens when a disease is described from the very beginning, that those cases which are described are the most severe, the most dramatic ones. And of course, it seems like this new disease, it's going to be something like something that kills a lot. And what we've learned within time is, of course, there are very severe cases, but most of the cases, the vast majority of the cases, are asymptomatic, and they will never present with any symptom throughout life. And this is what we've learned, that what we can say now, it's sometimes I tell my patients that from all the things that we deal with, I would say that Brugada syndrome is one of the most, I would say, positive ones, because you don't need to take medication. You just need to avoid certain things, and the vast majority of the patients will never have a single symptom or any type of heart condition. So this is the most important. I think this is the most important thing. And then we have to focus on the really severe ones, which are normally presented in the pediatric life. And that's what we see.
And I think, when I think about that, good news of that, for the most who get titled Brugada syndrome, it's not a big deal. Measures. When I think of the glass half empty, I find myself heading over to the genetic basis of Brugada. I think that has been a frustrating chapter in some ways. Incredible excitement not quite 30 years ago when the sodium channel was found, and then everybody kept saying there's going to be more and more and more, and yet the yield of genetic testing for Brugada has stayed pretty much etched at 20%. And some of us, yours truly, started raising our hand 20 years ago and said, maybe the reason why we're not finding more monogenetic Brugada is because maybe most of Brugada is not a single genetic hit disorder. And I think that's taken a while for everybody to understand, both the physician community who orders these tests and still seem to be surprised when it comes back negative, and then the community of Brugada families themselves wondering, why isn't their Brugada type known and what's going on? Your reflections on this kind of roller coaster we've been on from the genetic discovery side of the equation?
Well, I would add to that, and I think it's very important that I am asked for many second opinions, mainly from Latin America and so on, and the physicians sometimes ask for second opinion for their patients, and they are very focused on spending the money for a genetic test, which is sometimes a lot of money for certain countries because it's not covered by insurances. They have to pay it from their pockets. And I say, no, keep the money just for other things, because this is not going to change what you are going to do. It's not like long QT, which of course it's important to know which type of long QT you have. Brugada, 80% of the time is going to come back negative, and the 20% is going to be positive. Okay, yes, it's positive. It's very interesting to know, but it's not going to change to be a big deal on the patient. So I always tell them, just keep the money for something else.
Speaking of Latin America and other second opinions that you're doing, I'm wondering, and you're saying keep the money and focus on something else. You think part of that focus is on the legitimacy of the diagnosis in the first place? And what I mean by that is I seem to see, and maybe it's a referral bias, what feels like a tremendous overdiagnosis of Brugada happening, with very subtle ECG patterns getting tagged with your uncle's name, a Brugada pattern, when I'm not even sure I would call that worthy of their last name at all. And I'm just curious, are you seeing an overdiagnosis when you're doing all of these second opinions?
Absolutely. I think that there is a lack of information in physicians, and when there is something that catch your eye saying, okay, this might be something, you need to say yes or no. You cannot be in this gray zone, which we hate. We hate gray zones here, because there's going to be a big deal after that, whatever we say. So I like to say, yes, it is. No, it's not. And many patients have well maybe diagnose, which is very dramatic for them, their lifestyles, because people that tend to live in the grays tend to give gray recommendations as well. So sometimes saying something which is not really the case, like don't do sports, for example, or be careful, you cannot take any medication in the world. So it's like, okay, we need to really, it's very important to have a clear diagnosis of yes, no. And of course, sometimes we keep it in the grays because we don't know it. But it's very important to have clear in mind which are the tools for the diagnosis, and if we are in the black or in the white, and that's it.
Yeah. And I'm going to go to a question because I think Kyle's first question really helps focus this now on pediatrics, like you said, and where you've been particularly influential and important with respect to understanding Brugada behavior in children. And I'm really curious what you're going to say on this, because I've wrestled with this whole fever thing, because I think we have, well, I won't bias your answer yet, but Kyle's asking for a child with asymptomatic type 1 Brugada. So let's just assume that it's truly Brugada and it's truly SCN5A mediated Brugada. And again, a reminder to everybody out there, neither Dr. Sarquella Brugada or I am giving direct advice about your scenario, your situation. We're using your question to reflect in general about it, because a specific comment about your situation would be about a 90-minute evaluation from either her or myself to do justice to it. So with that caveat, is wondering that it seems that the pattern's only showing itself with fevers. And do you have a particular fever threshold that you use to tell your patients it's time to head to the emergency department?
Okay, this is the everyday question, and I think that here in Europe, in the States, and in China, you know,
Yeah.
of course, like at the very beginning, families tend to go to emergency department a lot, and after a while, they learn that they know much more about Brugada than the people who are seeing them at the emergency department. So, and everybody panics because nobody understands what's going on there. So at the end, the family learns a lot and learns how to manage. Which are my recommendations from the very beginning? It's like, just whenever there is fever, treat the fever. Just don't wait to treat the fever, because fever is uncomfortable for everyone, having Brugada or not having Brugada. So just give them some antipyretics, and then see if there are other measures like warm showers or warm bath, and take all the measures. And by giving ibuprofen or paracetamol, and if the temperature goes down and after a couple of hours goes up again, of course, because the effect it's gone, we keep giving medication, and then finally we will see that if we can control it more or less, it's okay. Of course, if there is very high fever, there's nothing that changes. Even we give the good doses of medication. We have put some warm bath, and we have done all of it that it's necessary. Of course, there might be an option to go to emergency department.
And for there, would you use like 40 degrees Celsius or 104 degree Fahrenheit as kind of a line in the sand, or for persistent fever that's just staying, rather than 38.7 and do an ambulance call?
Yeah, no. Normally it's high fever, persistent high fever. I have to say that sometimes it's more dangerous the speed of increase of the fever, the big change on the temperature that we have seen, that it's on the going up and sometimes down, that we can see that there might be more arrhythmias in those very severe cases. And remember that it's very important that most of the things we know by the more severe cases, and sometimes there might be biased in those asymptomatic completely cases with normal basal ECG, because this is an absolutely different situation.
And I'm guessing that in those cases where you are pretty strong about fever, you weren't wrestling with the diagnosis.
Not at all.
Because the ECG was obvious.
That's
And so now you're saying this needs to be taken seriously because it's not subtle, as opposed to maybe the majority where things are subtle and the diagnosis is a little bit flimsy in the first place. Because I kind of wonder, and I'd be curious if you think it's happened in Europe. I kind of wonder whether we have inadvertently freaked out the Brugada families by making them feel like fever is a 5-star alarm emergency and get to the emergency department stat because things are going to blow, when honestly I just haven't seen it. I know there are probably examples, but I don't have a single one in my practice. I personally don't send them to the emergency department for some of the very reasons that you mentioned. I tell them, pick your favorite antipyretic, whether you're like Tylenol or ibuprofen, I don't care, use it. And then if it's staying high, like you're saying, be aware, but many of the families are already have a personal external defibrillator for a worst case scenario. And I haven't seen that worst case scenario. So I tend to be way more relaxed about fever, I guess, and more just, okay, let's do the fever drill, but let's not be dashing to the emergency department. But I feel like I'm in a little bit of the minority when I find a lot of peds EP doctors conveying to the families that it is an emergency. And it sounds like you might be closer to me than the everything's alarm and it's spooky.
Yeah, I think that we know exactly which patients we really are very careful with the fever. Those which have a very abnormal ECG at baseline, and that probably those have already done arrhythmias, and those are carrying ICDs already.
Right.
For those who are normal patients that we see that because we know they have Brugada because daddy has Brugada and we did family screening, then those, of course, it's always nice to have an ECG with fever, because even if with fever we have a normal ECG, then we are really, really relaxed. And but not because of the fever, because we take the opportunity of the fever to see the ECG. How does it change?
Yeah, I love that. And that's where I actually find myself encouraging, if you can get to an ECG or get one recorded in the fever, it's usually those that have kind of a wimpy, they might have true mutation, but they have a wimpy electrocardiographic expression. And now you and I are just curious, does it go from wimpy to obvious in the setting of a fever, or does it stay wimpy? And if it stays wimpy, then you and I are telling them that it really looks pretty underwhelming in that owner of that genetic marker.
Absolutely.
Let me scroll down to Lisa's. So we'll take Lisa. Oh, that's a great name, Lisa. It happens to be my wife's. And she from Instagram is sharing with us, Georgia, that her EKG shows Brugada pattern type 1. Doctor said no symptoms, no family history, and to come back in 2 years. How should I be monitored and what treatments are available? So in general, an asymptomatic adult, it sounds like, a woman, no personal story, no family story. What's kind of your drill in general for that kind of a individual?
Okay, so I would say no treatments available because there's no need for a treatment here, and there are certain people that use quinidine for those cases, a spontaneous type 1 ECG, which I don't do. But I would say that the only thing is that if possible, the avoidance of those drugs that might amplify that Brugada ECG, which are the drugs that are in the list, that there are sodium channel blocking drugs, if possible, to be avoided. Because sometimes we know that we have diseases that need those treatments, and the danger for that disease is bigger than the danger of having a complication after receiving that drug. So I really think that in those cases, it's important to, of course, treat fever, make sure that there is no dehydration, as always said. Dehydration is not good for any situation in this world, and of course to make sure that if it's possible to avoid those medications. Treat fever, avoid medications. No treatment needed.
And for Hannah and her daughter, they are SCN5A positive. Their team is saying that their symptoms are Brugada-like in nature. We'll have to try to unpack that a little bit. But they apparently have a normal ECG. They're symptomatic, though, with VT, SVT, and atrial fibrillation. Does that mean they could still have Brugada syndrome? We'll start with that, and then she has a follow-up question.
Okay, well,
maybe SCN5A, but a normal ECG at rest, and yet having a variety of heart rhythm abnormalities being documented.
Well, I think that having ventricular tachycardia, supraventricular tachycardia, and atrial fibrillation with a sodium channel mutation, okay, this might look something. Even if you don't have an ECG of Brugada, you have something, because you are having a wide variety of arrhythmias that they can all go with Brugada syndrome. They can go to other syndromes as well. But even if you don't have the pattern, those arrhythmias are something that red flags should be up, because mainly because of ventricular tachycardia. And having a daughter, I guess, she's young with atrial fibrillation. This is something which, at least for us who treat children, a child with atrial fibrillation has to be looked with big eyes, because we all know that sometimes there is something underneath.
Now, would you be a buyer or a seller if there was a true SCN5A loss of function mutation, and yet the owner of it has a normal PR interval and does not show the Brugada pattern? Do you still think they can do arrhythmias like's being reported, or would you be wondering, feels like something else is going on?
Yes. Yeah, normally when we have a normal ECG baseline with a true sodium channel pathogenic mutation, either the genetic is not good or either the ECG is not from that patient, because it's very rare that you have a big thing with normal ECG.
Yeah.
Then I would like to see which normality is that normality, because sometimes we receive ECGs being told normal, and we start seeing those prolongation of the PR interval, widening of the QRS, and certain bundle branch blocks or something like that. So really, I never trust an ECG, that a report of an ECG. I like to see the ECG myself.
Right.
What gives me much more confidence. But it's true that someone being young, or not young, with ventricular tachycardia, supraventricular tachycardia, and atrial fibrillation, this is something that has to be looked carefully, especially if they have a sodium channel mutation.
Yeah, indeed. And then Hannah's follow-up, and I'll grab it, is what's the state of gene therapy for SCN5A Brugada, because she has 7 family members affected? Not yet. And so the bottom line is, you've been hearing about gene therapy for some of the potassium channel disorders, but the SCN5A gene is too big in terms of its size to fit into one of the current deliverers of the therapeutic cargo, which are these things called AAV. So we're working on it. We think we have some ways to overcome the size limitation, but it's quite a ways behind some of the other gene therapies that our SADS Live community have been hearing about. Chris from Instagram is wondering then, if you're asymptomatic, and I guess let's say you have a positive genetic marker, and he's wondering, is the syndrome only diagnosed after an event? So I guess it gets at, what is the definition of is?
Okay. So I think this is one of the questions that have been changing a long time. As how do you diagnose a Brugada patient? So of course, when you have a Brugada pattern and you have ruled out other causes of having that pattern, especially a pericarditis, which is the inflammation of the sac that covers the heart. If you have ruled out that, if you have ruled out thoracic malformations, if you have ruled out what we call ups and downs in the dehydration or in our ions, all that, if it's negative, you need to have a positive type 1 ECG in order to talk about, at least to talk about Brugada syndrome. If you have what it's called type 2, type 3, that's not diagnostic at all. And there are many people that they have never had type 1 and they have been called Brugada and they have never had a type 1. So this is very, very important. So do you need to have events? Of course, Brugada syndrome goes with associated with sudden cardiac arrest, and that was at the very beginning. But we want to diagnose it because before sudden cardiac arrest arrives. So overall, it's important to know that that part is the one that sometimes we can get in a confusion if we really need to have had an event or not to have a diagnosis of Brugada syndrome. But with a sodium channel mutation and a type 1 ECG, it's something that it's pretty clear that we could call it Brugada syndrome.
Kim's wondering, Georgia, why does that pattern change all over the place? And let's say somebody truly has the Brugada genetic marker, but she's saying her daughter can have a type 1 pattern on one ECG. Another time it's non-diagnostic with a so-called type 3, but she was healthy on every time she gets an ECG. So why does that pattern come and go in some people, whereas in other ones, like the ones you were mentioning earlier, the ones that you and I are more worried about, is where every single time they get an ECG, no matter what, the pattern, the type 1 pattern, is rock solid there and obvious, versus the others where it just kind of, sometimes there's like hide and seek, sometimes there, sometimes not, sometimes there. What are some of the whys behind why it might come and go?
Well, this is the reason why we are never confident that the patient does or does not have Brugada, is that ECGs come and go. And sometimes a patient, we need to do 10 ECGs to have one positive or suspicious ECG. So why is that? Because there are many things that will influence this ECG, like temperature, as we have said, hormones, at which moment of the cycle of a woman we are in the month, related to estrogens, low estrogens, and mainly testosterone, which is what we know most. Of course, the ion situation in our body, once again, dehydration, and there are many other situations like what we call after we eat, what we call postprandial. After we eat, our stomach relaxes and it's full, and this can provoke what we call a vagal situation and a lowering of the heart rhythm, and that may induce changes in the ECG as well.
Mm-hmm. Kate's wondering, are there any other genetic markers outside of SCN5A? And for Kate, it's kind of interesting, isn't it? I think SCN5A was discovered with Brugada in 1996, so not quite 30 years ago. As it turns out, Kate, since then, there were 22 other Brugada genes published. Of those 20, so at one time, there were 23 so-called Brugada genes, but then all 22 of those 23, except for SCN5A, have gotten tagged with a demotion, meaning not so fast. Maybe they're not self-sufficient disease causative genes. Now, it turns out sometimes we throw out the baby with the bathwater, so to speak, and perhaps some of those 22 will make it back on the list because they really are legitimate disease genes, and we just have to mount the acceptable amount of evidence to prove it. So maybe not those, but anything on, will we ever see the so-called polygenic risk score to be helpful to explain why somebody might be showing the Brugada pattern when their SCN5A test is clean? We're not using it yet. No company in the United States have brought in the polygenic risk score. Do you think we should? Are we missing something? Is it just kind of academic? What's your take on the other complex genetic architecture stuff?
Well, I think there is a lot to know, and of course, we want to have a polygenic risk score. We want to have something. I mean, we want to have some information to tell people either if they will be able to give an answer, a genetic answer to that. And I think that we would love to give a response. And of course, we are developing genes, polygenic risk scores that will help us with that. Are we there yet? I don't think so. We are working on that, but
let me see this one. This is a good one. And this will probably be our last one from Jason. For a Brugada patient, no symptoms, what Apple Watch notification should we be concerned with? And I guess maybe we could take it a step forward. Do our Brugada patients even need that, unless it's just something they love?
Well, probably they need it for other reasons, not for Brugada. Apple Watch is not giving you a clear, well, it will give you the idea if you do arrhythmias, you will detect those arrhythmias. One of the most common arrhythmias in Brugada, it's early atrial fibrillation, not early in children, but we can see atrial fibrillation at age 40, 45. So an Apple Watch or other devices are good at detecting atrial fibrillation. In fact, they have been made for that. And they are good for those arrhythmias. Is it Apple Watch or any device useful to detect the Brugada pattern? Not yet. There has been now one cardia from a LifeCore. We have a 12 lead, what it's called 12 lead device, which can help you for that, but it's not something that you can easily use. You need to branch some electrodes, but it can be useful, but there's no point on having that in a common way routinely. Of course, it's very easy to wear a watch, but not easy to wear something attached to your body all the time.
Yeah, that might be an interesting place for the fever assessment, though, right? So what if the families, instead of dashing to the urgent care or the emergency department, just puts on that cardia device and then sends to us what the child's ECG looked like in the setting of fever and for that diagnostic effort. So maybe it will have a place for that purpose. Yeah. Well, we're coming to the top of the hour, and Dr. Sarquella Brugada has something really exciting to announce, to put on your calendars for the Spanish-speaking community on Brugada. So, Georgia, give them the teaser.
So it's something to save the date. On the 4th of October, which is a Saturday, we are going to have our yearly meeting for families. It's going to be in Spanish. So it's going to be during Spanish hours. But of course, all the Spanish-speaking community, it's more than welcome to join us. So probably through SADS, we will post the link. SADS and SAMS, which is the Spanish Association for Sudden Arrhythmogenic Death Syndromes, are sister associations, and this is very important. And I will have the pleasure to have you on board and also to join all the activities that we are going to do.
Wonderful. I look forward to hearing about how that seminar goes for you. And Georgia, as always, thank you so much. Thanks for taking part of your Friday evening to be with us. Now get back to your family and And to all of you out there in SADS Live, thanks for joining us today. We loved your questions. We hope you enjoyed the answers and our conversation as much as I did. And I will see you back in SADS Live for session 165 in 3 weeks on May 21st. Until then, for next week in 9 days, an early happy Mother's Day to all of you moms out there. May you know how precious and cherished you are, and may you be blessed. Take care, everyone.
Bye-bye.